Okay, all that's to build up to what we're really here to talk about is a sleep disorder called sleep apnea. When it comes to sleep disorders, we've got a whole bunch to choose from. So we're really going to talk about sleep apnea. So what is sleep apnea? Apnea means to not breathe or to stop breathing, and sleep apnea means we're going to stop breathing at night. Hence, we're the lung specialist, we get to be in that. So sleep apnea is typically, there are now thought to be 3 mechanisms for stopping breathing. When I was trained, we thought it was one, just all compression, anatomy, the way you're built, end of story. That's really not true. There's now proposed to be 3 mechanisms, which really sounds more logical, and some of it's respiratory drive, some of it is throat dilator muscles, and the rest of it is anatomy. And then we're not going to talk about hypoventilation syndrome, we're not going to talk about respiratory failure, we're really only talking about pure sleep apnea when it comes to this. So there's 2 types of sleep apnea. One is obstructive sleep apnea, which is throat closure, airway closure, either by anatomy or the vasodilator muscles of the hypopharynx kind of close down, lose their tone, or don't have enough tone. The other type is your brain's respiratory drive is not telling it to breathe. So that's central sleep apnea. And so now the rest of the talk, we're really going to talk about all obstructive sleep apnea, not central. All right, and then the causes of sleep, this causes sleep disruption, meaning most people with sleep apnea come in to see me and they say, no, I sleep great, I sleep all night, no problem. And their spouse says, no, you don't. We do the study and we say, oh my gosh, you've got an apnea-hypopnea index of 60. And they say, no, I don't, I sleep all night. So we have that debate with them and tell them what that really means and all the sleep fragmentation. So what that means is once a minute they stop breathing for long enough, they get an oxygen saturation that goes down by 4, and it has to be accompanied with an arousal of the brain. And it doesn't have to be completely awake, but it has to wake up into a higher level of sleep. So you go from deep sleep to level 1 or level 2, that counts with the desaturation. So we put that together, but all that leads to sleep fragmentation and prevents them from getting deeper sleep and enough sleep. And you'll hardly see any deep level sleep in people with severe sleep apnea. They will have to get to REM sleep every now and then so their brain knows that it's going to die an autonomic death if it doesn't get you there. So it'll get you there every now and then for glimpses of 3 seconds and 5 seconds and 10 seconds, accompanied with that really low oxygen level until there's a startle and an awakening. So it's an anoxic brain injury and severe sleep deprivation. And each one of those causes neurologic problems. Okay, risk factors are age, sex, weight, comorbid diseases, and the complications. We've just been through a whole ton of what happens if you don't. We now know there's a lot of data on heart attack, strokes, arrhythmias, all the monetary, all the money data on this really has to do in the cardiology world. We can increase a cardiac output by 10 or 15% if someone has a cardiomyopathy and we treat their sleep apnea. If we treat their sleep apnea, they have less recurrence of atrial fibrillation, less need for ablations, less pacemakers, less failed cardioversions, less hospitalizations, less CHF. All that translates to dollar and cents, but it really translates into better quality of life, better care, better outcomes, living longer. So a bunch there. This is one of my favorite. If you have patients who are a little bit, I have a difficult time communicating sometimes, especially with some of my people my age, more in particular, but I'll have them go to this, Harvard did this great presentation with Shaquille O'Neal on sleep apnea, and it's great, and you can't argue with it. It's done really well, and you got the Shaq telling you all about his sleep apnea. So it's really done well. So I direct a lot of patients to that, and it's very well received. And that's, of course, that's going to be on my website and on the presentation here. But that's a great example. The second example here is our 400-pound kind of person with severe sleep apnea. And this is one that I use that in a lot of our public talks. We'll put that on, and I'm surprised at how many people say, oh my gosh, that's half my family. But they didn't know it was abnormal. They just thought that's the way it is because that's the way everybody sleeps. So there's examples there that you can use with your patients. We talked about the possible 3 mechanisms. I don't want to go into that in any more detail. And actually there's an increased incidence of sleep apnea based on we're all getting older. There's an increased sleep apnea as we age. And then as a society, we're getting bigger. So as our BMIs go up, there's a higher rate of sleep apnea. A lot of it because of throat compression and neck anatomy. Okay, this is some of the neat things I want to make sure you know. or I think it's neat. 50% of people who go to see a cardiologist have sleep apnea. 60% of people who had a stroke have sleep apnea. 30% of sleep apnea occurs in people who are thin or normal body habitus. So it's not everyone is big. This is a great one. For those patients with bad heart issues and sleep apnea, you cannot rely on their sleepiness. They can come and say, I'm not sleepy at all, and for some reason, they lose the ability to understand and know their body's sleepiness from within. So in the cardiology patients, you can't listen to them. Whatever they tell you, you say, I don't care. You've got sleep apnea, we're treating you whether you feel great or not. Or then they come back in and say, Mom, I'm on this doggone machine. I hate it, and I still don't feel any better. And you say, well, I don't care. You know, you're on it. It's going to save your life. It's going to help with arrhythmias. You're going to live longer. And the studies show what you feel doesn't really impact your physiology. You're not capable of expressing that feeling to us in a way that I can understand and is statistically significant. Okay, we talked a little bit about recurrence of atrial fibrillation is cut by 50% when you treat sleep apnea. Look for it when the BMI is over 35, but that's only in 2/3 of people with sleep apnea. If a lady has a neck circumference of over 15 inches, or if a man has a circumference of his neck over 17 inches, is an independent risk factor for sleep apnea. Something called a Malapati score that we're going to look at. Anyone here intubate people or help intubate people? Okay, we're going to talk about this a little bit. You've seen when you go to intubate somebody, this is that throat you look in that just frightens you. All right, if you have hypertension with 2 or more medications, there's a 50% likelihood that you have sleep apnea. And then this is the construction. The way we're constructed on the inside in our cheeks and jaw and tongue structure has a lot to do with the way that our genetic heritage. So really there's a much higher risk of severe sleep apnea in our Asian, African American, and Pacific Islanders, Philippine descent, which is it's just amazing to see all of that and not really be appreciated. And then any association with metabolic disorders, there's called Syndrome X, is hypertension, cholesterol, and diabetes. And when you see those 3 things, there's a very, very high likelihood that there is sleep apnea. And some recent data from the National Sleep Foundation just showed that 85% of people with diabetes type 2 have sleep apnea. So it's really, gargantuan. Okay. These are some things looking at some of those mechanisms we're not going to talk about. These are some risk factors for sleep apnea and kind of why they're so much. And the neat one is not a neat one, but a strong one is the family history. If you have somebody you're genetically related to with sleep apnea, you are at a 50% chance to have it during your lifetime. Now, it may not be until you get to a certain age or until you get to a certain weight, but you share those genes and some of that structure. Okay, consequences, I think we talked about this already. This has now changed. On my lowest one it says insulin sensitivity and diabetes, no data. This is now, there's a lot of data showing that this has changed. So there's new stuff out there really impacting insulin resistance and diabetes mellitus, and in fact control. So I'm sorry that slide's a couple years old that I grabbed to put in there. Okay, obstructive sleep apnea increases a lot of things about it. So there's a close link with sleep apnea, sleep deprivation, and some underlying psychiatric disorders. And this is really, really important. And a lot of our payers are now understanding this, since some of our new medicines cost so much to prescribe when it comes to bipolar or severe depression. Now they're interested in this. And Humana's coming up with a policy that all their people with depression, whether moderate or severe or certain medications, need to be screened for sleep apnea because they know that if they're treated, that their depression's better, they need less medications, they're easier to control. So this slide kind of goes along with a lot of that. Okay, this is an increased risk with cardiovascular disease. CVD means cardiovascular disease. So the worse your apnea-hypopnea index is, the worse your outcomes are going to be from untreated sleep apnea. Okay, and this is some of our data, and this is a little bit older but still true. But if you have sleep apnea, you're at 5 times the risk for a traffic accident than untreated sleep apnea. Okay, this is looking at just the worse our apnea-hypopnea index. The more those episodes per hour that we have a breathing cessation, the worse our blood pressure is going to be. And you have to imagine when we talked about the way we wake up, with sleep apnea, you stop breathing, oxygen level goes low, the brain has this startle response to get you awake. With that, you get this flood of adrenaline. And that adrenaline is what drives your blood pressure to be elevated. So all night you're getting flooded with adrenaline and catecholamines, so your blood pressure is up all the next day. So this is kind of a correlate between severity of sleep apnea and blood pressure because of that. All right, this is a lot of the stuff that kind of goes back to some of those mechanisms we're not really going to talk about, but this is kind of the cycles of sleep apnea and what really happens. With sleep, we kind of go to sleep, we lose that airway tone. When we're going to sleep, everything relaxes. If we're in REM sleep, we have no muscle tone, so things are really floppy and may close easily. Causes the airway obstruction, we get a low oxygen level. The longer this goes on, the more our brain tolerates it. You know, it used to be when we see SATs at 90, you know, we start to wig out a little bit. When they're 89, got to do something. When we see SATs at 60, you know, we're coding people, intubating them. Well, you know, amazingly, all these people at night have SATs in the 70s, 60s, and the 50s, and they're walking around the next day. Well, they're not okay, but they are really suffering profound, you know, brain glimpses of brain damage. And they have this preconditioning. Through the years, their brain has been so desperate to sleep that it said, I am willing to violate my physiologic threshold in order to get a couple microseconds of deeper sleep and a couple more. So we do that through the years, and that oxygen level learns to get lower and lower and lower. And there's actually a study through the VA that showed that there's a hypoxic preconditioning. If you have untreated sleep apnea and you code at the VA, your brain injury is going to be less when they revive you if you've had untreated sleep apnea, because your brain has learned how to cope with that. And that low oxygen level is not as profound as a deficit as the normal brain would see that. We would never wake up. Okay. Arousal, airway tone, we wake up, we cough and choke, we start to breathe again. So the arousals cause lack of deep sleep. We're sleepy, tired, poor cognition. That low oxygen level causes the heart attack, strokes, arrhythmias, hypertension, you know, the hypercapnia, all the other stuff kind of going with it. Okay, this is survival. And when you look at an apnea, the most significant drop-off there is with an apnea-hypopnea index of 30. 30 is where we characterize severe sleep apnea. So you see that kind of looking at follow-up, there's the big drop-off. And we have this kind of argument with ourselves or with kind of others about how significant, you know, mild, moderate, and severe sleep apnea, where do we need to treat? And I think some of that's the definition. And I think someday we're going to revise the way we look at this, because what we really should talk about is what is your apnea-hypopnea index while you're in deep sleep. And if you look at that independently, they're much different data. And the problem we have in our diagnostic studies, it's an average of what is your apnea-hypopnea index when your levels 1, 2, 3, and 4 sleep. So what really matters is what is it in your deep sleep. And if you only got 2 minutes of deep sleep on your diagnostic sleep study, you dilute out that severity. If you've got a lot of light, lousy sleep and it was still bad sleep apnea, your apnea-hypopnea index may only be 15. So it really, there's some variables here, but just severe sleep apnea is severely bad for you and survival drops off. Okay. When we treat people with CPAP, it reverses the trends in mortality and goes back to normal. There was a recent consensus, kind of a clinical practice paper published recently in the Annals of Internal Medicine on standards of sleep apnea and treatment and what do we know. The take-home message is that really there was no superior screening tool. As long as you're using a screening tool that asks you if you have sleep apnea, you're in bonus territory. So our Epworth Sleepiness Scale is not superior than the stop bang kind of questionnaire, but as long as you're screening, you're in the bonus territory. The other thing here was that when it comes to sleep apnea, a level 1 kind of recommendation, or the first recommendation was to recommend, if they're obese, is to recommend weight loss. Some people lose their sleep apnea when they lose their weight, not everybody. Recommendation number 2 recommended CPAP as the initial treatment as a very strong. There's most of the data that we have is really strongest with treatment of CPAP. The mandibular advancement device is down here at level 3. Recommends mandibular advancement devices as an alternative therapy to continuous airway pressure for those with adverse effects associated with CPAP, and that's a weak recommendation. And then there was really down here in this other kind of high value statement, it really didn't support surgery. You know, we do surgeries for people with sleep apnea, but it's really to reduce their apnea-hypopnea index. It's really to decrease their overall pressure needs, but rarely do we truly cure sleep apnea with surgery other than kids with huge tonsils and adenoids. We love to take those out, but as adults, we don't see success as often as we'd like, so it's really not supported with this Annals article. But of course, that's medicine data, that's not surgical data. Okay, so how do we look for sleep apnea? Well, we got to get a questionnaire. We'll go through a couple of those. We look for symptoms. The symptoms can be none. The most common symptom I get to see in my clinic sounds like, I'm not sleepy tired, I'm here because my family's making me come and I'm okay, it's not me. So you've got to be aware of that. And then otherwise it's excessive sleepiness, fatigue, lethargy, brain just isn't right, irritability, emotional ability, insomnia. We talked about the 50% likelihood of sleep apnea if you're related to somebody with it. We talked about demographics, age, race, comorbid disease, and then menopause is gargantuan when it comes to sleep apnea. Before menopause, women are protected from sleep apnea. There's 1 woman to 6 men who have sleep apnea before menopause. At menopause, there's some protection that is lost, and it's not as simple as estrogen, progesterone, or some of the hormones we know how to look for. But after menopause, sleep apnea is a 1-to-1 ratio in men and women. So menopausal sleep problems aren't just hormonal and hot flashes. They can be the development of true primary sleep disorders that really need to be treated. Otherwise, there's significant morbidity and mortality. Okay, then I always look at a physical exam. I'm going to show you some things. We talked a little bit about the neck size already. We need a body mass index of over 35 as a risk factor, and we're going to show you the Mallampati score. This is the Mallampati score was developed initially. When you're going to intubate somebody, you want to predict how easy or hard are they to intubate. Mallampati 1, you can see where the tonsils could have been or should have been, the uvula, the tongue, the tonsillar pillars. In Mallampati 2 is twice as likely to have sleep apnea. Here the throat is somewhat closed. You get to see the uvula sometimes you see the bottom of it at the tongue. Mallampati 3 is, I can't find, the uvula is that little thing that hangs down the back of our soft palate. In slide class number 3, you kind of lost where the uvula is. You can't see it. And this isn't pushing down with the tongue depressor. This is when you open them up, look with the light and say ah, and it's that jaw opening, not a tongue depressor. And class 4 is those people, these are the ones that we usually, have a hard time intubating. When you look in their mouth, there's no way, you can't even see, up or down, and it's, good luck. But the class 4 are 8 times as likely to have sleep apnea as a class 1. So this is on our exam. This is why we're looking in the mouth and looking at those things. Now with kids, we love to see huge tonsils. See those huge tonsils, say, oh my gosh, you've got huge tonsils, no wonder why you can't breathe, let's take those out. In adults, it's not like that. Okay, this is an Epworth sleepiness scale. This is a tool that we have to judge sleepiness. It'll be in the presentation. You're free to take it or use it. Epworth sleepiness scale of more than 8 gets our attention. More than 10 is we need to talk about it. More than 12, you've got a problem. Okay, stop bang questionnaire was developed mostly out of the surgical data, and it really was shown that when you do screening pre-operatively and identify sleep apnea, you improve outcomes. You have less infection, less codes, less disaster in the recovery room, less pneumonia, and much better outcomes, better wound healing, better recovery. So there's clear data in the surgical literature to support the stop bang questionnaire, but in this it covers the S is for do you snore, T of stop bang is for tired or symptoms, O is for observed stopping breathing or apnea, 4 is the P for pressure, let's see, the B in bang is for BMI more than 35, the age, if you're more than 50, unfortunately is an independent risk factor for sleep apnea, so A for age, N is for neck circumference, 15 in women, 16 or 17 in men. They've kind of rounded up here to an average of 15.75 is what they used in this questionnaire. And then male gender is an independent risk factor, even though we said the menopause thing, but we're presuming there's some premenopausal kind of women in this post-operative or preoperative screening. So if you're yes to more than 3 of those, you're high risk for sleep apnea. If you're no, you go ahead and get your surgery. You're probably going to be okay. Now, when we test for sleep apnea, in the old days, we had a polysomnographic study, and then in our definitions, you can click on that, go see the hookup, see what it's all about. It is a big deal. The cost for that is anywhere, depending on private pay or if you're hospital-based sleep lab, anywhere between $380 and $4,800, depending on your lab and what your affiliations are. So it's a lot. It is the gold standard. It shows us every single thing about any sleep disorder ever, if we're smart enough to interpret it correctly. That is the gold standard, big variations, big costs. There's now home sleep testing that's done. And home sleep testing only looks for sleep apnea. Can't look for any other sleep disorder. But if there is significant sleep apnea, these are actually pretty good at picking them up. And there's I put a whole bunch of stuff here, but I don't think for our purposes we need to do much. But the cost is a big factor. The cost can be 1/5 to 1/10 as much. And today's kind of high copay, many patients say, hey, if I got to pay all this, I'd much rather go with this one first, where there's a chance it's going to find the disease. Okay, and then this is just types of studies. There's all sorts of classifications for the full polysomnographic study in the lab, all the way to different kind of home studies that are available. Okay, this is what we really want to talk about in some ways. Now, you all are going to be on the front lines of sleep apnea in many ways. And in it, I think what you're going to see a lot of is being forced to, if you're in a hospital venue, someone's desaturating, some trouble, you are going to be forced to put CPAP on somebody. So it's not forced to, but you're going to be assisting them in wearing a CPAP machine or getting their airway open or getting better airflow and opening up their airway. So I want to kind of show you a lot of different things. But in sleep apnea, there's a couple other treatments. If you only have sleep apnea when you're flat on your back, well then the answer is don't sleep on your back. Now, when I'm asleep, I can't control what position I'm going to be in. Most of us can't. But there are some elaborate devices that you can strap on, almost like big belts with big spiky things behind them, so you can't really effectively roll over on your back. There are shirts with pockets in the back you put little balls in. So most everyone wakes up in the morning with a sore back because they slept all night with little balls in there, and they still sleep on their back. But the other stuff can work. I think the spouse is the biggest way to get positional therapy, but then your spouse isn't very happy with this. So we hardly ever recommend positional therapy, or usually people find that out on their own. And this is why people say, oh no, I only sleep on my side, or I'm a belly sleeper, I can't sleep on my back. And why is that? Is there orthopedic problem? They can't really tell you. And it's because their brain has taught them that their sleep apnea is not as bad if they sleep on their belly or if they sleep on their side. So it's kind of taught them to survive better that way. But it's not what we recommend. Okay, weight loss can really be dramatically helpful for sleep apnea, and 2/3 of those people are obese. For every person, if you have 6 people who go from heavy to ideal body weight, however, only 1 out of 6 or 1 out of 5, depending on the study, will lose their sleep apnea. So the majority don't, but it's still, you get all the benefits, and certainly treating sleep apnea actually improves your metabolism, so you burn more calories, and actually helps you lose weight. So some people, we put them on CPAP, we let their metabolism rev up, give them a good diet, and some of those people lose weight, and 1 out of 5 or 1 out of 6 will lose the sleep apnea. That's the best treatment I could ever hope for. Okay, mandibular advancement device is a fancy term. The mandible is our lower jaw. Advancement device means we're going to pull it forward as much as possible. By doing this, we take the base of the tongue and make it more anterior, gives us a little bit more room to breathe at night. This can really be a great treatment for mild sleep apnea. If it's anything worse than mild sleep apnea, it doesn't treat it completely, but treating it some is better than none. So in those people who don't want to use, if they have mild apnea, we go with this right off the bat in some people, depending on their preference. If it's worse than that, we try to go with CPAP, tell them about this. If CPAP fails, they don't like it, we talk about this. And the downfalls with this can be TMJ syndrome, moving the teeth, mouth dryness, a couple things about it, but certainly it doesn't require electricity, it's easy to travel with. If you have mild apnea, this is something we should consider. Okay, surgery, a whole bunch of neat new things about surgery. There may be an implantable, you may have seen it, but it's now FDA approved, a kind of a pacemaker for a muscle, or actually around a nerve, and that nerve innervates part of our hypopharynx and stimulates the oral airway to be more open. And this may actually work, one of our 3 mechanisms. The data, I mean, it's FDA approved. Some of the preliminary data is actually pretty promising, but it's something that we're going to kind of wait and see. There's no one in our area who does it anyway. So we're waiting to see how that works out. And I'm not going to jump on that bandwagon until there's like 3 years of good data. The last product like this that was released, within 3 years it was back off of the market because of erosion and because of other things that really wasn't perfect. With surgery, I group in there bariatric surgery. You know, this is where we get some success, and 1 out of 5 or 1 out of 6 of those people come off their CPAP and cure their sleep apnea. And then here's that implantable genioglosal nerve stimulator I was talking about. We have our CPAP machine, and then we have some other medical disorders that we have to take into account and treat. And you know, sometimes medicines make sleep apnea worse because it blunts our respiratory drive or our musculature. So we certainly want to address those problems, try to minimize those medications. And then we're always trying to re-educate people all the time on what is sleep apnea, why we're treating it. Okay. This is, we're talking a little bit more about the position, low cost, difficult to do, multiple apparatus are out there. Some of these people don't like to do it long term. They kind of wear out their shoulder and neck. This is some of the weight loss data. We're talking about diet, bariatrics. And then I'm big on trying to tell the truth. So when people lose weight, I guarantee them that we are going to retest and rely on those data. And some people don't. They just say, oh, lose weight and stop your machine. But having taken care of all those people in the ICU and their heart attacks, their strokes, their arrhythmias, you know, I don't do that. I really request that everyone get restudied when they think they're at their lowest weight. Okay, here's a result of sleep apnea in less than 20% on a successful diet loss program. Okay, MAD is mandibular advancement device treatment. We talked a little bit about it, effective for mild apnea, decreases apnea index. There's always a discussion about who pays for this. It's a dental device for a medical problem, and many times patients are stuck in the middle. When there's two, you have dental and medical insurance. One should pay, but usually the way it works out is nobody pays, so except for the patient. So I always want, when I send people to the dentist for this, I want to make sure they know exactly how it's going to work before they make a financial commitment. Okay. This is some of our surgeries. We still do some uvulopalatoplasties. I don't know if you talk to many people who have had those, and some of those people are very unhappy, and others are just a little unhappy. It can be a lot to go through, but if it cures the sleep apnea, which it can in some, if all the stars are aligned, and if things are really, their anatomy is if it's just right, that can be very helpful. And we do have a fair number of patients that get that. When we have people on a huge amount of pressure, pressure's 25 over 18, that's a lot of pressure contained in the mass. Those are people that I start to push towards surgery. They either can't tolerate the pressures, or it looks, there's no way to do that long term. They get surgery, and then their pressures come down to about half of that. And they can tolerate that pressure a lot more. They can tolerate treatment. They're going to be a lot more compliant. So, surgery we can use as a primary modality that may or may not work, but as an ancillary to CPAP, it helps compliance. It helps decrease the overall pressure. And we've done the same sometimes with a mandibular advancement device, but here in this surgical one, this is where we actually cut the jaw and bring the jaw out a month. There's some specific facial syndromes and other things that happen, and you can pick those people out. And just when they have very, very small jaw, you can just see if we bring that forward, we're going to fix a lot of problems. Tracheostomy always works. Of course, this is our last ditch effort to treat sleep apnea, but it always works. So we're always grateful for that. But I usually start from there when we talk about surgery and say, this is the surgery you'll read about. This is what we're trying to avoid. But if we can't do any of these other things successfully, this is what you're stuck with. And usually they get very engaged to really try to make one of these other things work. We talked about weight loss, the implantable upper airway stimulator. Okay, CPAP. All right, the way this works, you all know this better than I do, but sleep apnea is a closed airway in most of us. So a CPAP, continuous positive airway pressure, is pressure to help inflate the airway. And it's the pressure I describe to patients is you're going to pick up a flat balloon. You can't breathe through a flat balloon, but we want to inflate the balloon So it's going to inflate. The walls are going to stand apart, but we're not going to start to inflate it. We just want it to stand open. So it's that airway pressure we're trying to apply to the throat. And it has to be applied through either a nasal mask or a nasal and face mask or some type of interface. So we're looking for that pressure with a CPAP machine. That is our entire goal. And that pressure has to work no matter what level of sleep you're in and no matter what position of sleep you're in. You need the most pressure when you're in REM sleep on your back. So my gold standard of a titration study, when I'm reading studies, I refuse to say it's the final pressure unless we've seen them on their back in REM sleep. If they're not, that's not their real final pressure. You know, on some of the studies there's a pressure of 12, but if they weren't on their back in REM sleep, it's not. And then you've all seen the advances in some of our auto CPAPs. One of the goals of my use of auto CPAP is in that patient, I know they need more than 12 of pressure. You know, there was 12, but they're never in REM, never on the back. So I'm going to write for a pressure of 13 and above, 13 to 20 on that patient. And at least that's a starting point for that. So the goals of titration. BiPAP means two pressures in the nomenclature we have to use for insurance companies is we have to fail CPAP in the lab or can't breathe out against or show it's failed. So we can do bi-level or BiPAP. There's two pressures in and out. We have to be able to have efficacy and compliance are now trackable with our new machines, which is fantastic. Not only do we rely on symptoms, but we rely on all the data that comes to us. And really, now that the patients know we're looking at all that data, it's been much, much more helpful for compliance. When they know they're going to be looked at, and when they know they can't get it paid for, they are really more serious about using it because they know someone's watching. Okay. All right. The critical features of success is education, education, education. I spend more time trying to educate physicians than I do patients, it seems. You know, looking for this, how important it is, how it maybe manifests in cardiology and diabetes, you know, every facet. We need close follow-up. We need complication management. The old days where people were prescribed this, nobody knew who prescribed it, nobody knew who was going to look at it. They were getting updates. There was no one to really manage their complications, which is why a lot of people stopped using this or didn't understand. So it's a big part of our job and a part of your job, if you're doing this, is really managing, asking about those complications and how do we interface, how do we manage, how do we change. Okay. I am going to speed ahead a little bit. Okay, complications. One of the big things that you'll see this, and if you're in the hospital, you're going to see this. In the hospital, you may have 3 to 6 masks. There are a million different faces. So how does 3 or 6 masks really work effectively? Well, the answer is not very well. Or you're going to have to over-tighten the mask to get a seal, and it's uncomfortable no matter why it won't work. The patient doesn't like it. It hurts. So then we're going to restrain the patient. We're going to sedate them. That doesn't work at all. So really the interface for the mask is one of the most important parts of providing CPAP or BiPAP. And I go to a lot to explain that to the patient and the staff to say if we do the mask fit right, this is going to go better. And a mask fit is something that doesn't hurt, actually contains the pressure, but you only know that once you're on it and once you're using it. So when in a clinic, if we look at somebody, look at the mask, and I put them on, and I say, oh yeah, it looks like it's going to fit. I really don't know that. Until you turn it on, whatever their maximal pressure is, you have no idea what that's going to be. And it can look like it fits great to me, but 6 hours later in bed, it doesn't work right at all. So it really, our patients guide us to what that is. But having the more masks available and abiding by their preferences is the only thing we can do. And I'm also big on letting them fail with a couple masks, let them pick out, you know, and if they're going to have to decide it doesn't work. So don't push them into, you know, something we like because we think it works for us or we think it's going to work for them. I kind of give the patients that ability. You know, prove to me that the one that you like is really going to work or not work, and then let's go from there. So it's their choice. Okay, skin irritation is a lot. If there's skin irritation, it's either from dermatitis, from plastic. There's some things to do about it. One is called a Renzi's gasket. It's like a cloth from a t-shirt to make a gasket where the flange is. You put it on so you don't get that dermatitis. Another one can be, you know, skin erosion, cellulitis from the mask pushing in so much and being over tightened. How many people have seen that in our ICUs where we're on non-invasive ventilation for, just miserable, you know, and people, and I get to see that in the sleep lab as well, when people for follow-up with a big nasal bridge erosion, and my answer is like, oh my gosh, why are you putting up with that? And then like, oh, you know, I don't know, or I didn't call, or I didn't know what I was supposed to do. Or they put a Band-Aid on thinking like that's going to help, but you've got that mask pushing on every night. The answer is, you need a different mask. Okay. One of the other big things, nasal dryness, congestion, you know, we control that with humidity. We've got some nasal sprays. We talk about allergy treatment, Montelukast, a lot of ways around it. So don't let that stand in the way. There are things to do to get that better. Noise is a big thing. I am so surprised. Those of us who were around with the first machines that I think actually were pretty noisy, you know, now when patients complain of noise, you look at them like, are you kidding me? And this is nothing compared to what it would be like if you're snoring. So this is nothing. So if they complain of noise, I invite them to put their machine down on the floor or under the bed. And you know, it's harder to get to, but once they do that, they realize, oh, that's kind of hard, and it really wasn't that much noise anyway, so I'm going to put it back up there. Or sometimes the spouse is complaining of noise, which now the spouse is just complaining because this guy's going to live a lot longer because we're treating sleep apnea. Okay. Insomnia is a big thing. Now we talked about normal sleep. In normal sleep, we have those cycles with those built-in awakenings. So when we awaken, what are we going to notice? We're going to notice this mask and machine. We're going to notice skin irritation. We may notice the noise. We're going to notice something isn't like normal. We notice our bladder, pain, something on our face. So patients' perceptions are, oh my gosh, this thing woke me up. I hate it. Now my sleep's terrible. Untreated sleep apnea, HI is 60. I thought I was sleeping great. Now I'm waking up 3 times a night because of your mask and machine. My answer is, wow, that is fantastic. You just had normal sleep cycles, and you just awakened after each one of those. That is fantastic. And they kind of, you know, effervesce a little bit and say, oh, is that what it means? I really didn't know that. So just readjust your mask, push your ramp button. Wow, fantastic. Go back to sleep. You deserve another sleep cycle. So it's really kind of de-escalating kind of what that insomnia means and what it's all about. Okay, we talked now, pressure issues or something. Pressure on the nasal bridge erodes, but pressure can also inflate and go up to the eyes. Has anyone seen that? Kind of the eyes inflate. That can be, we have some little stoppers that can go in the lacrimal duct to kind of stop that airflow. One of the tricks that I like, I mean, certainly decreasing pressure does well to do that. So switching over to auto at lower pressure, so you only need that high pressure when they're on their back and REM, and then we decrease the pressure all the rest of the time can help. Or those blockers. So there's a couple strategies to doing that. And sometimes some nasal sprays have been helpful. The stomach distending is called aerophagia. A lot of people hate that, uncomfortable, and it doesn't make sense to me. We have some people with pressures of 25/20 who have no trouble. Then we've got somebody with a pressure of 6 who is dying tonight because of aerophagia. So it doesn't always make sense. But when you bring the pressure lower, it gets better. Now the problem is you're on a subtherapeutic pressure. So this again may be a role for using auto on them to decrease the total amount of pressure all night. Of course, it'll go up hopefully to the maximal pressure when they're needed at night, but it'll decrease the pressure at the other times when they don't need it. And then we tell them, I mean, some of it's kind of self-soothing techniques, or, you know, you're going to have a lot of gas, just bear with it, or use some Mylanta, but it really doesn't help. Okay, headaches can be a lot with this pressure and tolerance and already sinus issues, so nasal sprays can help. If headaches are there, I send them right to the ear, nose, and throat doctor. It's usually my sign that their sinuses are so bad to begin with that there's nothing I can do that's going to make that better. And they kind of get a free look and opinion about sleep apnea as well as their sinuses while they're there. Can't breathe out with CPAP. This is a CPAP intolerance. What do? We'll switch to auto or we'll switch to BiPAP. And then the biggest one here is the wrong pressure. Beware. 1 out of 10 times a smart card looks okay, but it's not. There's some residual apneas in there that we really were believing what we're being told, but when we send them back to the sleep lab 1 out of 10 times, we find that the pressures are wrong. So if people are complaining, be a little skeptical, or be skeptical and say, gosh, you know, look, I think we're on the right pressures, but maybe not. I've made all these switches, all these changes. I don't get it. We're going back to the lab. Maybe it's a pressure issue. I just can't tell. Or maybe now we're on too much pressure. Maybe you lost weight or your sinuses are better. We're over-treating you. No need to do that. Okay. Fear and claustrophobia goes a long way. We have sleep psychologists to help with that. Okay. So we want the correct pressure. We want to make sure that, we're not treating hypoventilation syndrome this way. We're really just talking about sleep apnea. By treating sleep apnea, we're preventing the hypoxic brain injury, and we actually help oxygenation with respiratory failure. There's some study when in the ER, they'll call and you'll put CPAP on someone in congestive heart failure. The mechanism that works is actually you're increasing the oxygenation, but actually, when you look at the dog studies, there's actually a role that the cardiac output is increased with a CPAP pressure of 5. And it really has to do with some venous return and augmentation. So there's a role there for oxygenation as well as increasing cardiac output. Okay, my take-home messages is, I always want to see somebody in about a month. Earlier, if they can't be on it, I want to see them that week. We cannot predict for them which mask is right, only they can tell us. We need to assess compliance. And then I just want to thank you for letting me be here. And I'm glad to take some questions either here or in the lobby when we're done. Yeah.
I have a quick question. What is the optimal pressure for a nasal mask? If somebody's like, I have to have that nasal mask, I can't wear a full face, what is the maximum pressure that...
I used to think I knew the answer to that, and I don't think there is. Because we used to say, oh, it's pressures of 10, you can't be on, it's going to blow up. But now we have people with pressures of 20 on nasal pillows or stuff, and they're doing fine. So that's why I think we should let them have it. And they'll tell us. Now, common sense would tell us, oh my gosh, it's going to blow out, or are you going to need a chin strap, or, it can't be that easy. But I would let them try. Good. Now, I'm certainly available for more questions if anyone wants afterwards, but thank you all.